I have the honor of presenting my old friend, Dr. Zeyad Al-Dabbagh, a consultant dermatologist. He's highly experienced consultant dermatologist and a fellow of the Australasian College of Dermatology over the last, with over 18 years of clinical experience. I first met him in Jordan 20 years ago. He currently practices at St. Sinclair Dermatology in Melbourne, seeing patients at both the East Melbourne and Pascoe Vale South. His practice covers all aspects of general, surgical, cosmetic dermatology with particular focus on pediatric, hair and scalp disorder, inflammatory conditions, skin cancer management, laser and cosmetic dermatology, and autoimmune disorders. He's got a Bachelor Medicine and Surgery from University of Mosul, and then moved to Australia and completed his training. Thank you.
Thank you, everybody. Thank you for IAMA for inviting me to do this lecture. This is my second year here, and thank you for attending. So today, I'm going to actually go very fast, but feel free to stop me. There's a lot of slides, but always I like to, is the voice clear or there's a little bit of an echo? Clear? Okay, perfect. So I always like to start with a photo of Sir William Osler, he's not a dermatologist, but he's a Canadian physician, and he was one of the forefathers who established the Johns Hopkins University Modern Residency Training Program, and he's the guy who switched from where dermatology was mostly descriptive and giving lectures, and then he took the students and taught them to see the patient and look at the skin as a window into internal diseases. One of his famous sayings, see and then see again. Good eyes are the best physician's best tool, and we miss more by not seeing than not knowing, and we'll try to implement these today as we work through the slides. So mostly we have around 3,000, maybe roughly, well-known dermatological conditions, but basically you could actually classify them into these, put them in one of these 10 groups or categories. And you have, so you have papulous squamous disorder and eczema or non-papulous squamous disorders being the most common ones. As you know, obviously, papulous squamous, well-defined, psoriasis is the prime example. Eczema, you have that ill-defined borders. Eczema, actually, if you were in ancient Greece 500 years BC and used the word eczema, everybody would have understood you because it was mentioned and used first by Hippocrates, and it means boiling from the outside in ancient Greek. And that's basically what eczema, due to severe itching. We all know that with eczema, we have obviously the most common atopic dermatitis, which is the infantile stage where you have the cheeks, extensor surfaces, obviously that's very easy to diagnose, and then the flexural distribution mostly in the children moving to the teenager year. One of the questions you get asked frequently is, when will my child ever be cured? Obviously we know that 70-80% of the kids will resolve when they're teenagers, but obviously 20-30% of the cases will go through the adult stage eczema, or they either have a mild generalized eczema, or they will have mostly what we have hands and periocular or orbital dermatitis. Eczema could be lichenified or subacute, like in this photo. They could have like the lichenification or the thickening, where you have the increased skin markings, and you have it acute. Tip is whenever you have an adult who presents you with just orbital ocular eczema, if they have history of eczema as a kid, yes, that's most likely common presentation. So the eczema resolves and they end up with just ocular eczema. If they don't have any history of atopic dermatitis, always worth to refer them for patch testing. And that applies also, the same thing applies to patients who have hand dermatitis. Obviously, contact dermatitis is a big one, but usually patch testing would be very helpful in those cases where you can't identify the trigger. I do get a lot of referrals with patients who have done all that radioallergist sorbent technique, that LISA for, the dust and mites and everything, or they have already been sent to a allergist. This is usually testing for the, immediate hypersensitivity reaction, which you have your urticaria as a prime example, and not eczema, which is a Th2 or cell-mediated, where patch testing is helpful to rule out the allergic contact dermatitis. So there's no kind of specific text for eczema itself. This photo, obviously you would think eczema right away, but always when you see a little bit of atrophy in the skin and that wrinkling, especially in an adult, and where you have more on the buttock or covered areas, always think to rule out mycosis fungoides or cutaneous T-cell lymphoma by taking multiple 2 to 3 biopsies. And it's very actually overlapping with eczema. And there was a study that was done on average 7 years delayed diagnosis by dermatologists, thinking that this is a case of atopic dermatitis and end up being mycosis fungoides. So usually it's not very easy picked on, but always keep a left threshold to do multiple biopsies. Nowadays with eczema, obviously we have many new options. In Australia, currently we only have the Rinvoq and the Dupixent. This actually is a nice website from the Skin Health Institute in Victoria. It's called EasyDerm. You could always just put it in. If you're not sure if your patient roughly will be eligible for you just put the numbers in based on the erythema and duration, and it's very easy. It calculates within a minute, 10 seconds you can finish. And usually any score more than 20, your patients will be eligible for these, which will make significant difference. Obviously, these JAK inhibitors are targeted even Dupixent injections. And there are many, obviously, in the drain coming soon, hopefully, if Donald Trump allows us to get these medications, because apparently he's not now allowing any medication to be sold cheaper than America. So another thing that I get, this rash in darker skin patients, always eczema in darker skin patients, most commonly, especially kids and teenagers, have a follicular pattern. So this is something that we see very commonly. It's not like in nitidus, it's not like in planus, eczema is very commonly seen in darker individuals, so papular or follicular dermatitis. Another thing, discoid, this is obviously contradicts what I said earlier when we said well-defined means psoriasis. It's one of the exceptions where you will have this well-defined plaques, round, circular. Sometimes they could be acute, or sometimes, which we call discoid eczema. Sometimes they could be subacute or even exudative. One of the things to differentiate them very easily from psoriasis, as you can see, usually the scales in psoriasis very well adherent, silvery, very difficult to remove them, right? While here, they're very fine, or pityriaciform, or more like mchala. They are very fine scales. So if you just get a little bit of a slide and you just scrape a little bit, then you will see this, what we call Osbit sign, pinpoint bleeding, due to the suprapapillary thinning and the dilated dermal papillae, which is very easy to diagnose if you're, obviously, sometimes we can't figure out by looking ourselves. Pumphelix, a variant of eczema, deep-seated papular lesions of sign of fingers, very itchy. A thing here is always to check. Pumphelix is a very common id reaction, so it's a reaction to an underlying infection, whether it's always look between the toes. Tinea pedis is very commonly associated, onychomycosis, any other skin infection. And patients are very surprised. I tell them, do you have like a little bit of tinea there? Oh, how did you know? It's very commonly associated with Pumphelix. Treat the tinea, the Pumphelix will go by itself. So Pumphelix, this hydrotic eczema, bullous, Pumphelix. I just wanted to speak a couple of words about dermatosis of pregnancy, because obviously we're always alarmed. We don't know, especially with pregnant ladies, we're very, trying to not prescribe or medications as much as we can. So usually with a dermatosis of pregnancy, 90% of your patients will have one of these 4 conditions. So when you see this condition starts usually mostly over the abdominal area, and it's accentuated over the stria. So you see these articulated lesions over the stria, then spread a little bit, It really respects the umbilicus area, so it doesn't involve the umbilicus area, and this is what we call polymorphic eruption of pregnancy. The theory is it happens usually in a primary patient, usually in the late stage of pregnancy. Why in a primary? Because you have the sudden stretch that happened in the abdomen, and you have the damage to the connective tissue, the collagen, and this creates a kind of, the theory is a cell-mediated immune reaction that causes this reaction. It doesn't affect the baby. It's very common, resolved within 4 weeks. You reassure the mother, a little bit of topicals, good old steroids will do the trick, or antihistamines. Another one that you see that actually, sorry, this is the same thing. So this is actually a better photo where you see the accentuation. It's called polymorphic eruption because you may have it at dermatitis, but most likely it's urticarial, let's say. This one where you may have blisters. When you see a blister in a pregnant lady, always make sure to biopsy because you want to rule out pemphigo gestationis. And this actually does not respect the umbilicus at all, the umbilicus region. It involves it, not like, that's one of the hints. And it's also mostly concentrated on the abdominal area. This actually could cause preterm delivery. It could cause small for age babies. So always it's very important to promptly diagnose it. Another very important one where you don't see a primary skin lesion. So basically intense itching, most likely starting like in the 3rd trimester. And you see a little bit of excoriation. So you think scabies, first of all, because there's nothing to see, just excoriation or prurigo lesion. Think always about intrahepatic cholestasis of pregnancy. It's not an uncommon one, and always doing a liver function test and a bile acid test, where always you will see that that is elevated. And I always do liver function test with any pregnant lady anyway with a bile acid test. And obviously it's due to the toxic bile acid and kind of crossing the placenta, and this could have actually severe consequences for the baby, fetal distress, and stillbirths. So this is actually the most important one you have to pick up. It's very easy to treat with a little bit of R-deoxycholic acid, which is a natural hydrophilic bile acid, which will treat the area. Obviously, always use our GI friends. We have many actually in our IAMA who we could always consult. Another one that starts mostly much earlier, this is the most common, maybe 1 in every 5 or 20 pregnancy could happen, which is atopic eruption of pregnancy. 20% of them have pre-existing eczema, but 80% is just predisposed during the pregnancy, like the adult onset atopic dermatitis, because now we have adult onset and we have late onset atopic dermatitis. Before, we used to think of it more of a newborn baby disease of kids. I am counting with you. Also, whenever you see urticarial lesions, like in here, with eczema lesions, there's nothing, as we were saying, like a type 1 and a type 4 together doesn't make sense. The only thing that could cause that, always think about scabies when you see both of these clinical pictures. And obviously, with scabies, checking for the boros, where that's the only, maybe somebody who's infected with scabies will have 7-8 mites, an immunocompetent adult. And it's very difficult to find these mites in the boros, linear tortuous lines, as you all know. So usually it's a clinical diagnosis. A very useful hint is these rubbery nodules in the genital area, the axilla around the nipples in the ladies, where it's usually the antigen itself of the scabies, where there has been formed acidolymphoma. Obviously, I'm starting, I don't know about you guys, but half of my patients who I prescribe permethrin are coming back with failure of treatment. There's apparently more of a resistance thing going in Australia, so I'm starting with ivermectin anyways, even with kids. Prurigo nodularis is another form of eczema. It's basically a lichen simplex, generalized lichen simplex chronicus. Iron studies is very important. Iron deficiency anemia, and also do a kidney function test. That's also, usually you see the butterfly sign because they're mostly induced by the patient and they can't reach that same sign you see in scabies too. We're still waiting the interleukin 31, hopefully soon, which will make a big difference in those patients. It's approved by TGA. Seborrheic dermatitis, cradle cap, obviously we all know that. Nasolabial fold involvement, retroauricular involvement, scalp involvement. Rosacea, on the other hand, very obviously, with rosacea, it's always important to know which stage of rosacea you're treating. You look at it as a more 3D dimensional, because erythematotelangiectatic, where you have the flushing and the fixed erythema later on, the only thing that will help with these patients is a little bit of vascular laser, or even you could give them actually this, Mirvaso. It's not covered by PBS, but it's an alpha-2 agonist that actually temporarily provides vasoconstriction. Many patients are happy just using, this when they have a certain occasion. Just one more minute. And also, when you have inflammatory component, you have your azelaic acids, your metronidazole. Also, I don't see a lot of GPs prescribing ivermectin, which is less irritative and also have better results in many studies compared to metronidazole and azelaic acid. Obviously, your tetracyclines, and then you have the isotretinoin, which is helpful. Not a lot of things that could cause cobblestoning of the nose. The only thing in dermatology that could cause that cobblestoning is rosacea. Also, always remember to ask about ocular involvement, which is around 15%. And finally, obviously, comedones will differentiate between acne and rosacea. That's the most common thing to look for and to know how to manage. There's a couple of others, actually much more slides, but hopefully at another occasion we'll be able to do another lecture. Thank you very much.